So in the previous lecture, we discussed up till warfarin and the management of bleeding due to warfarin. We discussed that as well. Today, we are going to discuss. So let's do an example and then we'll start our next topic. So a man on warfarin fell and presents with confusion. His INR was found to be 6. What should be done? What should be the management of this patient? A man on warfarin who fell and presents with confusion. His INR is found to be 6. What should be done? Anyone? Patient
IV
on
vitamin K.
IV vitamin K initially and
then later on by mouth. And stop warfarin for a few days.
so IV vitamin K, stop warfarin, and what other things we can do in this patient?
Prothrombin concentrate.
Why prothrombin complex concentrate?
Is it a major bleed? Like he's
read the scenario and tell me, is it a major bleed?
Yeah, because he fell and he's having confusion, so looks like it's a major bleed.
Yes, it's a major bleed. So what will be the management? IV vitamin K and prothrombin complex concentrate.
Concentrate, or then fresh frozen plasma later on.
If PCC is not available, then fresh frozen plasma. Otherwise, no need of fresh frozen plasma. Fresh frozen plasma is an alternate for PCC. So we discussed in neurology chapter that old man with on warfarin with a history of fall and confusion. So what will be the most likely diagnosis in this case? An old man on warfarin and a history of recurrent falls. What should be the diagnosis?
Subdural hemorrhage.
Yes, that's right. Subdural hemorrhage, chronic subdural hemorrhage or acute subdural hemorrhage, it can be caused by use of warfarin and in elderly patients. So because intracranial hemorrhage is a major bleeding, so we'll give prothrombin complex concentrate along with IV vitamin K. Prothrombin complex concentrate, it contains clotting factor 2, 7, 9, and 10. So our next anticoagulant is heparin. There are two types of heparin. One is low molecular weight heparin, and the second is unfractionated heparin. So low molecular weight heparin, it has a molecular weight of 5,000 daltons The example of low molecular weight heparin it include dalteparin, enoxaparin, and tenzaparin. All the drugs that are ending in parin, Parin, they are low molecular weight heparins. They inactivate factor 10A, so they form a complex with antithrombin 3, and this complex inactivates the factor 10A. The mechanism of low molecular weight heparin and unfractionated heparin is same. The only difference between these two is their molecular weight, and uh, the other difference between these two is that uh, it is better than unfractionated heparin. It has more efficacy. So that's why it has replaced unfractionated heparin in the treatment of uh, venous thromboembolism or acute MI or non-elevation MI, etc. So the preferred drug in all these cases is low molecular weight heparin because its efficacy, it's more efficacious than unfractioned heparin. Both of them can lead to bleeding because they are anticoagulant. They can cause heparin-induced thrombocytopenia as well. Osteoporosis can also be a side effect on used for a longer duration of time. And one more difference that you need to remember that low molecular weight heparin, it accumulates in renal failure. So that's why lower doses will be used in case of renal failure. Either lower doses of low molecular weight heparin or unfractionated heparin, because unfractionated heparin does not accumulate in a renal failure patient. So in short, the difference between low molecular weight heparin and unfractionated heparin is that low molecular weight heparin is a low molecular weight substance, and unfractionated heparin is high molecular weight. The response of low molecular weight heparin, such as dalteparin, enoxaparin, and enzaparin, it is more predictable, and no laboratory monitoring is usually required if we give low molecular weight heparin. And the other difference is that lower doses of low molecular weight heparin is required in patient with renal failure, while the dose of unfractionated heparin does not need to be adjusted in patient with renal failure. Both of them can lead to bleeding, and the antidote for bleeding due to bleeding due to warfarin was vitamin K, and the antidote for uh, unfractionated heparin and low molecular weight heparin is protamine sulfate. Protamine sulfate, it combines with heparin and unfractionated heparin and low molecular weight heparin and eliminated by the body. It forms a soluble complex with both of them. But remember that protamine sulfate is basically a antidote for unfractionated heparin. While in case of low molecular weight heparin, all the effects of low molecular weight heparin cannot be reversed with the use of protamine sulfate. So it's a better antidote for unfractionated heparin, while 60% of the effect of low molecular weight heparin can also be reversed with the use of protamine sulfate. So this was all about low molecular weight heparin and unfractionated heparin. These are some anticoagulants such as warfarin, heparin, and low molecular weight heparin. Now, some other anticoagulants that you are familiar with, the newer one, direct acting oral anticoagulants. They
Sorry,
include
can I just
rivaroxaban and
ask one question regarding this antidote? So, in low molecular weight heparin, this protamine sulfate is not effective, but the other one, which is unfractional heparin, we can use the protamine sulfate. This was
It can be used in the toxicity of both of them
it can be used in both.
because yes, because there is no antidote available for a low molecular weight heparin. So we don't have any other option
Right.
but to use protamine sulfate because some of the effects of low molecular weight heparin can be reversed with the use of protamine sulfate.
But for unfractioned, this is a specific antidote, the
Yes.
protamines.
Yes.
Okay, okay, thank you.
Other anticoagulants they include fondaparinux. Fondaparinux is basically a pentasaccharide. It is also a 10A factor inhibitors. So all these heparin and low molecular weight heparin and fondaparinux, they inhibits the factor 10A indirectly. So they are also known as indirect anticoagulants. Now there are some anticoagulants that inhibit factor 10A directly by combining with factor 10A and inhibits it directly. They include rivaroxaban and apixaban. So we all know that now, according to recent guidelines, these direct acting oral anticoagulants, because they have a less chances of bleeding and they does not require any monitoring. So that's why direct acting oral anticoagulants, they have replaced all the mm, drugs and they are now as used as first line drugs in the treatment and prophylaxis of venous thromboembolism. So fondaparinux, though it's not a low molecular weight heparin, fondaparinux. All the drugs that are ending in parin, enoxaparin, for example, enoxaparin, they are low molecular weight heparin. Fondaparinux is a different drug from fondaparinux is basically a pentasaccharide. The mechanism of action is similar as of low molecular weight heparin, and the actions or the effects of fondaparinux are also similar to low molecular weight heparin. So it can be used in place of low molecular weight heparin. It can be an alternative for low molecular weight heparin. And remember that there is no antidote available for fondaparinux, and it is not neutralized by protamine sulfate because we discussed that low molecular weight heparin can be neutralized by protamine sulfate. About 60% of the effects can be neutralized by the use of protamine sulfate. But there is no antidote for fondaparinux because it is not neutralized by protamine sulfate. So this was all about a brief description of anticoagulants such as warfarin, heparin, and direct-acting oral anticoagulants. All of them can also result in bleeding because they interfere with the clotting factors such as factor 10A. And we all know that factor 10A convert prothrombin to thrombin. So when factor 10A is inhibited, no thrombosis or no clot formation will occur, and the patient blood will get thin. So with the use of these anticoagulants, there are chances of bleeding. Now, patients who are on warfarin and they are undergoing going for a surgery, they need to stop warfarin because warfarin is a long-acting drug and it is difficult to manage the complication of warfarin. That's why, because during surgery, the chances of bleeding is increased. So if a patient who is on warfarin and he is undergoing a surgery, he need to stop warfarin 3 to 5 days before the surgery. And because the patient may still need anticoagulation, so heparin is usually started instead, and this is called heparin bridging. Why heparin started in place of warfarin? Because heparin is more easily and rapidly reversed. That's why it is preferred in patients who are undergoing surgery. So after stopping warfarin, surgery can take place when the INR is less than 1.5. So heparin need to be stopped 5 days before surgery, and surgery can take place when INR is less than 1.5. Now there is a specific category of patients who require heparin bridging. Heparin bridging is that when we stop warfarin, but in high risk patient we need to give an anticoagulant. So we'll give heparin. So there is a specific population of patients which require this heparin bridging. Now the example of those patients which require heparin bridging, they include a patient who has a thromboembolic event in the last 3 months. So heparin bridging, the first indication for heparin bridging is someone with a history of venous thromboembolism in the last 3 months. Atrial fibrillation with a history with a previous stroke, someone with a history of atrial fibrillation and a previous stroke, someone with atrial fibrillation and a Chers-Vasek score of 5 or more, a recent transient ischemic attack, and patient with mechanical heart valves. So these 5 categories of patient, they require heparin bridging. In all other patient, only stopping the warfarin and do the surgery when INR is less than 1.5 is required. While in these patients, heparin bridging is necessary. So remember that if patient is only having warfarin with a Chadwick score of less than 5 and has no previous stroke, he would just need to stop warfarin and no heparin bridging would be required. So this was all about anticoagulants and their management of their complication. I hope it's clear to everyone. Is there any question?